is the engagement officer. So my primary roles are to look at and identify if there are any health inequalities in screening or any barriers that prevent patients from attending for screening. And I work with the patients, other healthcare professionals, GP practices, and people in the community to try and find a solution if we're able to. We also have started engaging with communities to understand. We like to look at whether our screening programme is accessible to everybody. And one of the things that we constantly review is, do we have enough screening sites? You know, can our patients get to them? Do we cover our geographical location well enough for our patients to provide this NHS service? So that's just a little bit about me and the job that I do. So I've just put a brief little sort of content slide together just to briefly go through what I was going to cover today. So I'll tell you a little bit more about our programme, the patients who should be coming for diabetic eye screening, obviously why it's such an important health check, what we do at the appointment, and then obviously, like Adam says at the end, if anybody's got any questions, I'm more than happy to answer them if I can. And if I can't help, my manager's logged on as well, just for a bit of moral support. So the North Nottinghamshire Diabetic Eye Screening is one of over 50 diabetic eye screening programmes in England. So we cover North Nottinghamshire. We've currently got around 24,500 patients under our cohort, and we cover the parts of Nottinghamshire which are Ashfield, Mansfield and Newark and Sherwood district. There is a Greater Notts programme that some of you may be more familiar with, so they cover the south of the county and the city centre, and we do work closely with them as well. We do liaise, you know, with them, and a lot of our patients sort of move between those borders, so we're familiar with each other and work together really well. So North Nottinghamshire, we have 37 GP practices that refer into our programme in those areas. And that is the way of referring into our programme. So we're very reliant on the GP practices. That's the only way that a patient kind of really gets referred into our programme, and how we're made aware of those patients needing screening. So I've just done a brief slide on who should have diabetic eye screening, because it can be confusing. There's lots of different sort of clauses of patients who can and can't, so I thought this might be really useful. So anyone with a type 1 or type 2 diagnosis of diabetes who is 12 years old or over should be referred into our programme and should be having diabetic eye screening routinely at least once a year at the moment. Routinely once a year, possibly twice a year at the moment. Anybody under the age of 12 wouldn't come through to our screening programme, but any concerns, that those patients would be referred to an ophthalmology clinic at the hospital. Anyone with MODY, which is the rarer, more genetic form of diabetes, which it stands for maturity onset diabetes of the young. So anybody with that specific type of diabetes should be having their eyes screened. Anyone who is already diabetic but becomes pregnant, so those patients will obviously be already referred for having screening, but just to sort of highlight that those patients will be asked to come for screening a little more regularly during the pregnancy, because diabetic eye disease can develop more rapidly, obviously in the hormonal changes and different changes that go on in a woman's body while she's pregnant. Steroid-induced diabetics. So these are patients who have been prescribed probably a longer term of steroids, can develop diabetes as a side effect of that. We do ask that those patients are referred to us for screening, because the changes in the eyes can happen and can be exacerbated because of the rapid onset of the diabetes. The difference with this group of patients is that once the steroid treatment has stopped, the diabetes tends to resolve and go away completely, and a GP practice will do all the necessary checks to ensure that that has resolved itself. And once that's happened, that patient doesn't then need to come for diabetic eye screening. Obviously, unless such things as the GP thinks that diabetes is a more long-term thing and it develops into maybe a more permanent form of diabetes. And then the final one, I've put this in capital letters because this is the one that tends to cause the most confusion amongst patients: diabetics in remission. So this is mainly applied to type 2 diabetics. So once a type 2 diabetic, if they do all the things that are asked, that are required, so maintaining a healthy diet, stopping smoking, regular exercise, reducing alcohol intake, it is possible for a type 2 diabetic to reduce their blood sugar levels down to a number that means they're not actively diabetic anymore. So comprehensive studies have been done, and it has been proven that these patients can still develop diabetic eye disease. So it's really important that patients whose blood sugar levels have come down to a normal level are told that their diabetes is in remission rather than it has gone away. Yes, it's not actively causing them a health concern anymore, but they can still develop diabetic eye disease. So it's really important that those patients do continue to come for that screening every year, just to make sure that that's checked. Patients who are classed as a low risk category may only be asked to come every 2 years. So once they're determined to be at a very low risk of developing disease, then they'll move on to a 2-yearly pathway, so would only be required to come every other year. So I pinched this next part from Diabetes UK because I think it sort of sums up why diabetic eye screening is so important. So as you can see, over 1,300 people every year who have diabetes lose sight that could have been picked up and prevented. And I think when you drill that down to 25 people a week, I think that really hits home that it is a serious condition, but it can be checked and picked up early before it starts to cause any problems with a patient's sight. Hence why obviously other screening programs exist to try and obviously try to identify it at an early point of view and try and hopefully allow the patient to put things into place to try and prevent it from from getting any more serious. It isn't all so it's really important that patients continue to go for a sight test. This doesn't replace a sight test. This is as well as it's so a patient, we always recommend patients continue to go for the normal sight test as and when they are supposed to go annually, or every other year, or more sooner if needed. But it's really important, obviously, that they have this as an extra test if they're diabetic. Diabetic eye disease can't always be picked up in a sight test, and that's why as a screening program, patients who have the screening have dilating drops to identify diabetic eye disease, because it can't always be routinely picked up when it's at a very early stage from a sight test. So it is really important that both those checks are done. And diabetic eye disease doesn't always present with symptoms until it's at a very advanced stage. So a lot of our patients say, oh, my eyes are fine. That doesn't mean that there's not disease present. It just means, it could be there, but it may not have got to a stage where you're starting to notice changes in your vision, or you're starting to notice a deterioration in your sight. So again, one of the reasons why it is one of the really, along with the other health checks, but it is a really vital health check as part of your diabetic care. So again, just to highlight, I know I've gone over some of these, so just the sort of, you know, main important things just to reiterate about diabetic eye disease. Like we've said, good control of a patient's blood sugars can significantly reduce the risk of a patient getting diabetic eye disease, or where a patient has diabetic eye disease at very early stages, it can prevent the risk of that from escalating to something more serious and them needing to be referred into hospital to have further investigations and or possibly treatment. The reality of diabetic eye disease, it can result in total sight loss if it's left undetected and untreated. Again, you know, reiterating the importance of coming for screening when you're called for screening. And as we've mentioned before, a patient may not notice changes in the vision until the disease is advanced. A lot of patients that we speak to, and we try to, one of the big things that we do at our programme is we try and speak to a lot of our patients who aren't attending for screening to try and find out why they aren't coming. Is there anything we can do to help them? A lot of our patients are of a working age population. So I understand the complications of this. I work full time myself, so I completely understand sometimes it's really difficult to fit things in around your working week. And I understand obviously that not everybody has a job where it's, you know, they're flexibly able to take time off work for appointments. So one of the things that we ask, sometimes we ask our patients to think about is, what would you do if you lost your sight because you hadn't come for screening and you developed diabetic eye disease on a more permanent basis? You obviously wouldn't, these patients wouldn't be able to attend work. And obviously, a lot of our patients, as we know, a lot of people care for other family members, and that you know, completely understand that takes up a huge amount of somebody's time, and often means that people put themselves on the back burner. But one of the things that we you know, we have to remind patients of is that obviously if your sight was severely impacted, or you lost your sight completely, would you be able to care for that patient or relative? And then obviously there's the loss of independence for a patient. You know, if you can't see it, you know, you can't watch the TV, read a book, read a newspaper. Obviously attending social events, appointments independently then becomes more difficult, and then you become more reliant on obviously other people having to help you. And that sounds very extreme, but it, you know, it is the reality of what could happen if you know, if this eye disease is left unchecked and untreated. And we try to encourage patients. We explain to them that the test, you know, it takes approximately half an hour, the actual test. So, you know, it's not a huge amount of time. We understand obviously people have difficulties, but we try to encourage them by giving them as much information as we can, so as they can understand how important it is, because unfortunately not every patient probably understands or has the information given to them to understand how important it is. Oh, it's just, that's it. So a brief, some information on what will happen during an eye screening appointment. So initially, when patients arrive for their appointment, there will be a vision test done, which they will probably associate similar to the normal sight test. We do have to check the level of vision a patient has. This can be useful for future screenings as well, because it allows us to look back at the history and identify if a patient's had a significant change in vision, you know, and obviously then that allows us as a screening programme to get them into the right pathway that they need to be as quickly as possible without any further loss of vision. So patients will be asked to either read letters or identify symbols from a chart. And just, as I say, just to check how well they can see at that appointment. So we encourage patients that remind patients it's really important that they do bring any prescription glasses if they have them to the appointment, so that we can make sure that test is as accurate as possible and the level of vision is recorded as accurately as possible. The next stage is to put drops into the patient's eyes to dilate the pupils. Now, we do have a lot of patients who don't like this. Yes, I completely understand. It's not the most pleasant experience having drops put in your eyes, but just to put it into perspective, they can be a bit stingy, but to put it into perspective, it's a similar level to if you got some soap or shampoo in your eye. It lasts a few seconds and then that stinging subsides. So it's really quick. You know, it's not something that lingers throughout the whole examination. And the reason that we do that is because the blood vessels in your eyes are so tiny, and there are so many of them, that the only way to get an accurate view of the back of the eye is to dilate the pupil so that the camera can see right to the back of the eye in great detail. Without the dilating drops, there is a risk that eye disease could be missed. And we want to identify even the smallest amount of eye disease. So it may be that a patient can just continue to come for routine screening. It may be that they don't need to be seen in the hospital, but they might just have a few changes to the blood vessels at the back of the eyes that we want to just be aware of. And in some cases, we may want to just get those checked out a little bit further at the hospital, just to have that monitored by an ophthalmologist. So the dilation drops are a vital piece of part of the eye screening process, and it ensures that we are, you know, we're doing as accurate a job as we can. And it is guidance that diabetic eye screening should be carried out with the eye drops in order to ensure its accuracy. So the next stage would be to take photographs of the back of the eye. The image on the left of the slide is a copy of what we would see. Those are the images that the camera takes. So that's an idea of what an eye would look like to us when the picture comes through. So 2 photographs of each eye will be taken of two different views of the eye, again to ensure that we've covered the area that can be affected, which is the macula right at the back of the eye, just to make sure that there's no changes. So in those blood vessels, what we're looking for, so new blood vessels can grow. The blood vessels that are already there can change shape. They can swell up, or when the disease is more advanced, those blood vessels can actually bleed, and it's at that stage where it can become a sight-threatening condition. So we can identify those very minor changes from those images, and obviously then that allows that patient to have knowledge at a very early stage of what they can possibly be trying to do better to manage the diabetes, to try and stop that disease from progressing. The pictures that are taken, so all of our screening sites are at opticians' practices in the community, with the exception of one health hub that we have in the Ashfield area, which is an NHS premises, and it's used as a diagnostic centre, and various community appointments are held there. So our systems all link into each other, so all the practices use the same piece of software that we all use, and any time a screening is undertaken, it's automatically transferred over to us. We then have a group of what we call graders, who are fully trained, in a lot of cases opticians, but we're not opticians. They all hold an accredited qualification and have been through rigorous training, and continued quality assurance testing to make sure that they are reviewing those images accurately. So those images will be reviewed by what we call a primary grader initially, and they can go through up to a 5-step process really. If necessary, those images where there's uncertainty, where there's you know, disease that's identified to be more severe, they'll actually go through to one of the ophthalmologists at the hospital, who will review those images and will be responsible for making that final decision on what level of severity that patient's eye disease is and what they need to do. So it's a really rigorous process, and fully accredited, constantly reviewed to make sure that we are as safe as possible and providing the best service that we can for our patients. Results will then be sent out. This is usually done within 3 weeks of the screening taking place. And patients, we send patients a letter, so they'll be written to confirm the results of that screening, and the GP practice will also get a copy of those results. So the results will either confirm that that patient needs to come back yearly or twice yearly. If they're deemed to be at low risk of developing severe diabetic eye disease after so many screenings, they'll be asked to come. They won't have to come every year anymore. That's a new piece of guidance that's come into play. If a patient needs to be seen in the hospital, but on a routine basis, so we don't, at the moment, the level of eye disease is potentially developing into sight-threatening eye disease, but isn't at that stage at the moment. We refer patients routinely into the hospital eye service, and their care will be taken over by the ophthalmology team at the hospital. If a patient is deemed to have severe sight-threatening eye disease, we will speak to that patient first. We won't just send them a letter. We'll give them a ring, because it's quite a big thing to have something like that come through the post and not really have any information. So we'll speak to the patients first and explain the whole process to them. We give them an expectation of how long they would have to wait for that appointment. So they're fully aware of every step of the way what's going to happen from now, and then we'd send that results letter out to them after having that conversation with them, so that we know that they're fully informed. So that's an outline of how the screening process works at the appointment and the bit after the appointment. One of the big things that I've put at the bottom there is that obviously the drops can affect your vision, so they can make your eyesight a little bit blurry. It's not that you can't see once you have the drops in, but it can affect your focus and your ability to read close up. Writing, things such as that. So it is recommended that you do not drive until your vision has returned to normal. It can take up to 6 hours. Everybody's different. But we always recommend, initially we recommend our patients don't drive to their appointment, but we certainly do explain to them that they must not drive after the appointment until their vision's returned to normal. So we would always ask a patient to perhaps maybe bring someone with them, or get someone to bring them if that's possible. If not, advise them that they shouldn't be driving a vehicle until for up to 6 hours after the appointment. And that's really everything. I hope I've covered everything, but that's a sort of a snapshot in 25 minutes of diabetic eye screening. So thank you for listening to me. And then I've just